Okay, good morning, ladies and gentlemen. Good morning to our discussion leads. Welcome to this session, a design workshop on access to quality healthcare for all. So my name is Maria Sale. I am a volunteer with the NESG. I am thematic lead for the public health thematic group. So that's a subgroup or subcommittee under the Health Policy Commission. I think also in the room I have lead for the Health as a Business, which is the other thematic group. Dr. Benson, you want to say hello quickly? I was introducing you while you were speaking.
Thank you.
Yeah. All right, so this session really speaks to the importance of access to quality care and the importance for Nigerians. A few days ago actually, the key indicator results, right, of the 2023 NDHS was going viral on public health WhatsApp. I don't know if anybody has had a chance. We haven't made much progress. I think with the exception of family planning, I saw like a 3% increase in modern contraceptive use, but things like neonatal care, we slid backwards. Things are still looking quite bad, and it's not surprising. In terms of inputs, we're not doing as much as we can. And then in January, the NESG, I think it was a poll or so that the NESG had deployed to just regular citizens, looking at what people thought were the most pressing issues that should be discussed in the NES 30, that's during this summit. And healthcare polled very overwhelmingly well, or negatively well, but 98% of respondents thought that it's something that should be addressed during NES 30. And so this is one of 3 or 4 design workshops based on the feedback from that survey that we are going to be looking at. We have the distinguished pleasure of having 3 discussion leads who are going to guide us through the discussion. We'll be leaning a lot on your expertise to find solutions to certain problems. So the way it's going to run is we have identified recommendations from the past NES summits. Health Policy Commission actually, I think, started in 2020, so we have maybe 4 NESs that we have participated in. So we've looked at all of the recommendations and split them into 3 work studios. Studio 1 is going to be led by Mrs. Vivian Ihe Kwazu. She's MD Nigeria Health Watch. If you could raise your hand. So she's leading Studio 1. We have Studio 2. Studio 1 is on financing healthcare workforce to reverse brain drain. So that's extremely topical. I know every day we hear in the news someone, 200, 300 nurses in the UK, 1,000 doctors have qualified, we have 10,000 doctors on the register in the UK. So that session will look at some of the things we can do to reverse it and retain the health workforce. How do we finance that? So the second work studio is led by Dr. Francis Ukuije. He is a technical officer, health financing and public health partnerships with WHO country office. And his work studio is titled Insurance for the Vulnerable and Effective Funding of the BHCPF. So all things health financing. That's Work Studio 2 on that side of the room. And then Work Studio 3 is led by, Dr. Francis. Let everybody know who you are. So Work Studio 3 is led by Dr. Laz Ude Eze. He's He's a public health physician and founder of Talk Health Niger. He will be leading Work Studio 3 in that corner of the room. Quality and access expectations of the average citizen, of the Nigerian citizen. So we know as experts healthcare quality is bad, but then what does the average Nigerian who has no healthcare background think, and what do they expect? So your discussion leads will first provide some context related to your thematic group, and then they will lead you or guide you through your discussions. And at the end, they will share some recommendations related to your thematic group, and you will be exploring these 3 questions. So at the end of the day, we want to know what is the current status of implementing that particular recommendation. 2, what are the obstacles or bottlenecks that remain to implementation? And 3, what recommendations do you have to the NESG to move some of these things forward? So we have flip charts in each group, we have repertoires, there will be no presentations, it's meant to be very organic, and at the end of the day, your discussion leads will present outputs from your group in plenary. So without further ado, so we are trying to group people into work studios. I think in the invitations, I don't know if it was indicated to you, but just feel free to move your chair to whichever side of the room you feel most comfortable contributing to. So again, as a reminder, Work Studio 1 is around reversing brain drain. Work Studio 2 is around healthcare financing. And then 3, at the other side of the room, is around access to quality care, perspectives of the citizen. So what and how can Nigerians demand more from the government? Thank you very much. So we can move into our groups. Just move your chairs anywhere you want to.
Okay. So those are the 3 main sources.
How would this translate into action?
Under the national health
also
plan.
awareness as to the people who are supposed to access that quality of care.
In ensuring that we have at least 1%. So the recommendation from the NESG was for it to increase to at least 2%. And indeed, there was a movement in the National Assembly to begin to review the National Health Act and increase that to 2%. Where are we on that? The third one is around accountability and transparency for health investment, especially around the basic healthcare provision for Nigerians. We are going to be looking at the systems that we have in place to ensure that even the little money that we have, though we are asking for more, we utilize them appropriately to get more help. So we're going to be dividing our time to be able to.
So I have more of a question.
But we're going to start first from
listening to what
health insurance.
My name is Media Lepe, but I work with management.
We will not do ourselves any if we do not recognize the
so
that have
we talked about sort of what the partners are doing.
that is why, because the DGNHIA is represented here by Dr.
But when you start to talk about what
to speak
the whole point of it is to have a
mandatory health insurance
standard. So it seems like there's fragmentation, right? What the partners are funding, what's happening kind of within the government, so there's two questions I have.
And later
One thing is about development documents, but then one also brings to that it's going to be different for homogenous and and then second time they also mention I think similar to what I was saying. It's one thing, it's not necessarily like bedside manner or some satisfaction, but rather how do you measure the outcomes and all these conversations that are happening, are they considering that already?
So I just wanted to say that the National Health Act is a very robust document that have all that covered. So he mentioned 13 out of 20. That is
so does that mean everybody who's doing that is adhering to those standards and they're following them?
It's a law.
Okay.
is a law. The national health is a law. For
And
health.
then there's the one for
And you can
mandatory health
pay
insurance,
this
not
for
to go about health insurance law.
But I think we
The third was on innovating financing, so looking at how do we finance. And the good thing is that that attempt has already taken care of the mandatory aspect, which ensures that whoever can pay should be made to pay.
to my knowledge,
Not in a way of carrying the pain after people and say, buy health insurance, making it attractive for people to buy.
or for health facilities.
In order to move the health system forward, advancing the health system forward, making it compulsory for everybody to register.
Based on which
Form of health
those who
insurance.
meet that standard,
Then the other one is the aspect for the vulnerable who cannot pay for their health insurance. So that act has also provided
so there will be a continuous
that what we call the vulnerable
to
group
ensure
fund,
that
which
those
the
standards
basic care
so it's not a
provision fund
one-off
we're talking about
kind
is
of
supposed to be
sanitation.
with other innovative sources of
So we say start surgery
and
and
so those committees have made far-reaching
I don't think anyone's ever put out the
recommendations that we are implementing currently. And for the vulnerable group, vulnerable group fund, the news is that the current application has a budget line for the EGF
was that pushing out the insurance?
voted, maybe
it's
not
not
the
really
culture
has
go
the
around
areas that I was
all the
talking about.
government in the country, but at least there's a
I
budget
still want
line.
to go back to
So
the
what we
national
can do as a group is
that
also
gives us the
press
guidelines.
for more
So
funds
before we
going
can,
there through the private
it
sector,
gives a very
which is
robust guideline as to
recognized,
how to navigate
through
this.
donors,
So, but many times we
through
focus on certain areas of the national
investment
and
by the
forget
health
about this area
insurance
of the
agencies
national
to also
the part that
pull
we
back
focus on is
into
the one
that
that has to do with our
particular
bringing
fund. So that
And that's the part.
83
So I
million
feel
Nigerians
that
that
if you go
the
back to the
Nigerian
national
Lancet group talks about
if you give
will
us
be
the
funded
guideline,
directly
or you may not give us the
EGF.
whole document as I said,
And
or
the
the
implementation
implementation
is going
framework.
to be through the state social health insurance agency. So when the fund is
Because even the BHCPA has its
committed
own
at the same time,
implementation
pulled
framework,
together,
but it was
then
pulled out.
distributed through the state social
I feel like we still need to go back
So
there.
basically, those are the issues, the plans that we have. We
that
need to
sounds
do a lot of advocacy,
Responsibility of
sensitizing
standards
for
lies
people
with
to
the
know
government.
about the EGF,
And it has
about
its
those
good
who
years.
cannot pay.
For that to happen.
And also keep
From
people
2014 to 2016, 2 years from when the act was
paid
made,
for
for all
employment,
that to
people,
be
formal
implemented.
employment,
So what it means that
informal
legally speaking, I
sector,
don't know if we have
because that's the very big
based on the
elephant
national
in the
health,
room.
no health facilities.
The informal sector is quite large in Nigeria.
Yes.
And so, when you implement health
So, we are
insurance
10
in a
years
society with high
But
percentage of informal sector,
let me get to the next recommendation from
you're always going to have challenges through public implementation. That's what we need to wrap our
And under that thing, we have ensured that public health care
All right, thank you very much, Dr.
focus
Gada. That
on
was very
outcomes
useful in
and
setting the
efficiently
stage in terms of where we are in mandatory health insurance. So having passed the law, the next is beginning to
public health care spending this
So,
time around.
guideline has been developed.
So,
and then some
which speaks to
structures
what the government
has been put in
and the
place.
local,
A
state, and
vulnerable
federal
fund has been appropriated in
So,
2024 budget.
what is the current status?
And I understand that it will be
As we are now, we are speaking as average
right now
Nigerians.
that NHIA to get some vulnerable groups into
May you wear your organizational hat when you think necessary, but the conversation is we average
when
Nigerians.
we have
So
mandatory
from that
health insurance on that,
perspective,
it does not mean that
we think
it's
that
going
the
to
public
be
health
implemented.
spending
Now I open
is
the floor based on what we know.
efficiently addressing
What do
our
you
healthcare
think is the
those
progress? We're not exactly
and
where
we have something to say
So,
on
how do you think we're coming forward with mandatory health insurance? But the law has said it is mandatory for all Nigerian, not only citizens, but all Nigerian residents. So what it means is that for the citizens of the country, and also for those who are working, legal residents who are also working in Nigeria, even when they are not citizens, mandatory health insurance. Maybe I'm thinking like you because you work with the state health insurance. What do you think that is the situation of mandatoriness? the state levels that are units of implementation of health insurance.
We as average citizens, how many people actually know what is unlimited health care in the country, and how can we hold our leaders and leaders of various countries accountable? Awareness is all boils down to awareness, how we can actually measure requirements.
So you guys, when the citizens are aware of what is happening, they'll be able to either ask the right questions or make the right demands. So like I was saying in the session earlier, we were talking about demand side. Essentially what we're looking is on the demand side. So in terms of product availability, logistics, procurement, supply side. So on this demand side, to what extent do you know what's arising? Patient bill of rights, spending budget. So those was in the OGP's days, with the current statistics, town halls, blue budget, publishing, make it accessible. So what extent is an average person, especially at some national level, able to do that for the basic healthcare provision fund? At some point, I posted in my community WhatsApp as always to health committee chair, the WBC chair. How much does the health committee receive?
We're going to get to that one.
And to what extent? So basically, going to make sure there was anything like that that existed.
Sorry to chip in. I actually don't want to
which at one point we employ some government resources. These people just get the resources, but
had no idea we were paying them a certain amount for health care. They were just lost when they were lost. Success of the
When you talk about public spending, I mean, folks working in hospitals don't understand. Well, the question is, how does the average citizen know how much should be spent, right? And how do you focus on outcomes? What do you measure? And at what point also do you then understand that, you know, based on whatever sort of standard or benchmark, this is where you're supposed to spend up to, and then maybe after that, you know, you're supposed to then have some sort of, you know, it's a very complex topic
to suggest to us what to do, we need to do. But I wanted to hear from the Bauchi Health Insurance Program.
So is there any investment in education or
Because I
recommended
know that the Bauchi program is also mandated. So I wanted to know what progress has been made in that direction.
Everything around
And there are some things you have already done. We can come to where you are going to
that should be
if you
the
may.
first thing. Because you cannot, if you don't, if you're not educated about something, you have nothing to control. You won't even know when you go to the facility and see whether they're standard or whether they're treating you well or whether like what the lab mentioned, they smile differently or something. So I think the first
20 minutes.
is for us.
20 minutes.
They should look upon us like a field practice. Train and educate CSOs, and then we have cascade down. But it must be very intentional in the sense that
Okay,
every
that's
time
beautiful.
education
So
is like
we've
an
gone
apple.
ahead to discuss the
We have to
possibility
do
of
many other things
integrating
like citizen education. That should be the first.
And is there a recommended budget for how much it should be? For how much it should be? Because we're talking about sort of, you know, public spending. So what is the recommended budget for education?
Exactly. And that should be, and then the education of the citizens should not be just CSOs or donors or funders. The government deliberately put money down as part of their budget to educate the citizens on what they are doing.
So that sounds very good. And this brings us to section national health plan to find the components of the health systems. started from federal
One
to state
is the issue of
ministry,
awareness. Because most people, especially the government, they are not aware
village health
what is happening. What is this?
pretend medicine dealers,
How do I
most of the effort and
What do I need to get?
including what we're doing with public healthcare from
One.
facility based,
The
community component.
health insurance
Because there is money
team
shared and people have to be signatories.
information
Now we have
coming out to the list to exactly
before we do partner projects.
there is
How
one
WDCs they get incentives at 10 meetings, then the project and everything will collapse.
the
Thanks to basic health
funding
care,
is talking about.
anytime there is things that alert not show, it is beginning to happen. And I say that because I'm a member of WDC in my community. I was asking too many questions, they stopped notifying me about meetings. Now them invite me, come to join though.
The 1% from the consolidated. That's many.
I don't know anything about
Look
it.
at it as
So
not anyhow.
we
Shouldn't
get
get from
these
consolidated.
governance structures at the community
Let it
level.
be from
People
let
have
that
more
1%
emotional attachment
not
to
consolidated.
their
Because it
villages
is
than
consolidated.
they do to the
It's
world.
only
Depending on how the world is defined, some
the
words
state
might
and
be
local
one
government will
country,
not be beneficiaries.
some words might be one
But when you say federation, it means the
both
state
sides
and the
talk
local
about
government are one
what
country.
political organization.
So what he's talking about that county care,
Many of the things
the
that
1% is coming from the federation, from the two and the 3 tiers of government.
so another thing
So when you
about
talk about consolidated, it's only the federal government. So that
political
the
authority
present
to settle
is
loyalties
only beneficial to the federal,
of whatever party that is involved,
and
including
not
those that are
the
not
state. So state have to have their own.
for
For
councillors.
them
It's
now
okay, come and
also
work.
have their own policy.
There is some money inside.
So I think
So
Okay, so you made very good point in terms of challenges, awareness, money is not
village that have governance structures at any
the
time.
population
And it is written that payment of responsibility.
but even for
We
government,
have health
that's the one that's coming from the federal government.
working with CSO, but we must acknowledge that these CSOs are not everywhere, they are not accurate.
But it should come from the federation.
Get them empowered,
But you went ahead to say that the states should
so
also
that if you want to do
participate
education,
so that
we engage the
the
health
states also
council.
contribute.
They know how to
what I'm
get their
saying
people
is,
to
if it is from the federation,
their town
it
hall
means
or
the
their
state
village square,
and the local
and you
government.
get those that know you are going.
That's the
So
federation.
you haven't made a suggestion that states
Those
should come.
existing
No, what I say is no.
Oh, you did? Okay, that's okay. No, it's not okay. That's okay. Indeed, the act had also said that the state should contribute. They are not contributing.
I didn't want to
That's
talk
one of
about
the things we know in the Yes, that's correct.
I think
Thank
that
you very
one
much.
of the best ways.
I think when
Luckily for us
discussing
in Nigeria,
this
we have
mandatory
communities
elements for insurance
that are doing
population, I have this problem,
we believe that the best way
which
to integration
especially for the basic healthcare information fund, when it comes to the state,
and integrate activities.
Okay, mandatory health insurance is different from basic health
In my own community,
We'll come to basic health insurance.
we have no one
Mandatoriness,
that's something
why
that
is
is
it a challenge? Why is it a challenge? That's what we want
yes,
to
the
talk about.
that fund will help to achieve the
These are the same people that also did
general.
So what you are saying is that the government should use the money to cover everybody and not ask
What
anybody
I'm
to
saying, when
contribute.
it comes to the state, that is the way it is.
No, let's not go there yet. Mandatoriness, yes.
So for it to be mandatory, when you cover things around women empowerment,
important that the national and
you
the
call
state
it,
align.
when it comes to things that will help.
That is
Like one
very
they went so far that in their women empowerment, they were
I think it is also important
They now took
for health
500
to
naira
be
out of
treated
that.
as a
Now we
business
talk to them.
and not just as a
bought
social
PP machine.
marketing tool.
They wanted something that would be sustainable and make them affordable.
The numbers also have to be calculated in a way that
Every
makes
month,
sense.
one woman goes
If
to
you
monitor
tell
that.
people right now there
One
is
woman
no
goes to monitor.
understanding as to how the computation is arrived at, So it is important for you to arrive. You say 12,000 naira covers 10%. How do you arrive? So it is important for me. What one of the challenges is lack of understanding how we have arrived at the capitation point, and then there is the inability to treat health insurance as okay. So lack of understanding as to how the capitations are arrived at.
Okay, yes, please go. Because you are from First Bank, I also want you to deal with this. Well, don't forget what you want to say. Because the law has said that it's mandatory for everybody. What it means is that you can't opt out. So First Bank, for instance, health insurance, social health insurance. So I wanted you to also look at that and what are the issues that the challenges with and just some other guys in the private sector. Yes, please.
What I want to say is, there is so much interest
Yeah, so just like we said, at any time, always they have existing structures which are very loyal to and they also hold in very high regard. So for us and what has worked for us is we start from the village head,
So is it
and then when we introduce him and we get his buy-in, he starts to tell you who you need to talk to assemble the people that you need. So there's always a team leader for the women and all that. And you call them, God has provided, she comes in, you explain them, you get their value, it's easier for you. They just help you make sure that the women see you and trust you. And once you have them, it's easier to get access to them and pass them information, educate them at the same time. So it has always worked through the head for us, and he tells us who we need to talk to, and then we help.
And also with
Who is the head?
No, the us.
Who is the also our team when we have to work in community thriving off initiatives. Yes, we are thriving off initiatives. So we work to promote new content and well-being in our community.
Okay, so I'll probably say
there's less emphasis because it's basically driven by profit. You understand? So every employer of the without it should be seen that it should be I'm employing somebody as domestic staff should have all provide. So there has to be like a system where things like maybe I think the regulation doesn't really go down to the monitoring stage.
So monitoring stage. Okay. Excellent. So thanks a lot. You've brought out very key points in terms of what needs to, in terms of the challenges we're having on the mandatory list. I have a hand here first, and then I go to you. You should wrap up on the mandatory health insurance. I know that that's one of the key issues, but because we truly don't have much time, we have to deal with that.
So thank you very much. Because of time, let me quickly respond on to the third recommendation. Still, be rounding up will now make specific recommendations and ESG, so that during subsequent studies, we want to look at how far what ESG can do as a group in terms of implementing many of these.
Motor insurance has been composed.
Strengthening public-private partnerships was recommendation 7 ESG, and specifically says build a strong collaborative framework
10 minutes, please.
for effective
10 minutes left.
public-private partnerships to improve access and quality of healthcare services.
Yeah, it's done. Okay, let's
Bring
come
it down
to
because when you talk PPP, usually the first thing that goes in mind is at the organ level, big companies and all. So since we are average Nigerian citizen looking at quality healthcare. So what public-private partnership matters at the community level now. Let me quickly share an experience. I was doing a project I called India Inspired Community Action for Health. That's what I called the app. So, and the idea was to strengthen community governance structures for primary healthcare, these village health communities. So what we did was had a radio program.
So what would be your
1 year radio
suggestion
program
in terms of way forward?
every
Because
week,
that issue
1 hour
about
interactive,
the supply side has been
national
raised
health
now.
and
So what would be your
what health
suggestion in terms
systems,
of what needs
what
to
they
be
needed to
done?
do. And we now challenge communities. People were calling talking about problems, our health systems not working. I will now say, okay, this is what your community can do. Does your community have a health committee? First, if you don't have a health committee, it means we are not serious about health. And the health committee is like
So you're talking about improving
and
the
community
quality so that it becomes attractive to those who want to buy it. And exactly that was the point. So would there be any other suggestion in that direction? Because I was quick.
Recognize authority at that level, village or community. For me. So after a while, some of them looking what we
Right.
So what next? So after that what next, we went to educate the sense of people, go that the village square or the health facility, they bring members and we made copies of the National Health Act and we gave them those copies. That's speaking to the education component. So we told them what their powers were. Gave them copies of the World Health System of the NPACD that apply the responsibilities, powers of the village health communities. I will tell them, you have powers. Health worker. You have power to reward the health worker who is doing fine. So after they say, okay. Another thing is it can begin to give incentives for private people to make these assessments, write your needs list, present it. Those who help you solve the problems will reward them. So you can use your award
we can also build on programs that have worked.
So as incentive, a local company that gives something.
We have done health insurance things
Some of them did that.
really work.
How do you build on the
success
town hall, which was
and learn from the pitfalls to avoid making the same mistake? What is the place of the social registers that we have?
Many of them were appearing on radio for the
Enumerating
first
the
time. It
vulnerable
was an incentive to share their
We
success.
have projects with
Call out
that
their
do
account
conditional
number.
cash transfers
And
that
when we
reach the
receive them,
informal
they give us
sector.
money.
How do we
Unlike
build
these
on these
people who
existing
were
frameworks so that we're not
so
reinventing the wheel? So
and
building
they
on
will
the
expect money
exercises.
from us. So this
Demonstrating
one, we
that
go,
insurance also works is important.
we stay wherever they keep us. After exam,
So proof of concept
take
for me
this
is
for free.
another recommendation.
They will
To
entertain
show
us,
that
not
insurance
us
works.
doing
And then
refreshment.
success
Buy
stories
refreshment
from
and
people
all
who have
that. And
benefited
it was
from
quite helpful. So out of
talking
like
to the
14,
supply side now. And then success stories where people can show that because they have a capitation of 12,000 naira, their wives were able to
their eyes
have a
open.
cesarean
They just
operation
say, what
and
we
they
just
paid
know,
nothing.
these are the laws. We are not the ones saying that. These are
So you wanted to say
if anyone that wants to challenge you, say this when you are driving your mouth. So at the village level. So now bearing that in mind, public-private partnership, thinking private and religious institutions which are very strong at that level. Private will also be business owners and everybody. So how do we use this, leverage this improving quality healthcare at that level? Very
So in answer to that, the national had already provided that the minister should provide the basic minimum
PPMVs are patents,
which is
private medical vendors, the chemistries that we come together.
lowest point.
This is just add one
And
comment.
once we
Like
have that, then we
like what you said, it's always that you might cause granular person selling something within the community who can support that. That's what part of that project. It was actually my boss in that project. Where we got
Very good. So I want to move on to the basic health provision. Let's talk about the basic health
that part of the
federal government
because of our adoption,
sending bodies to states
everywhere, things were coming in,
really is mainly from
as well.
1%
Apart from fences, it's just two farms. Not from new farms, just repaired.
there are some funds that are coming from the private
You will
sector,
not believe it.
not
The
private
difference
sector,
is we move from like
donors.
30
Bill and Melinda Gates Foundation has put in a lot of money into the system. The World
So
Bank
that's
has also
about the
put
PhD.
some money.
Somebody
But as of
who's not
today, this
so if somebody that are around
monies that are used to
those
provide
PhD
services.
areas, they can contact people with
So, for those
I was done with the state.
as a basic health
And then we have such things
challenges,
when you're
how
working
can we
with
do better? We can use that.
So
We
that's
also
where
have
everything
a
is
discussion on the third
not
part
when you're looking at
accountability
so
for
the
the basic
business here, private
health.
sector,
So
who are
let's go.
thinking, no,
What
but
are
I
the
don't
key
want
issues
something, and that is even the one that is more sustainable.
How do we
Because many times when they do that people, the person buys the big one and goes,
2% of
or she is small and
how do we crowd in
continually
the funding from
visits
the
the
other
communities
sources,
in the
private
world,
sector?
community ownership, community participation, and then you start to see.
Like I said earlier,
She
the
doesn't want to
1%
recognize
to
that.
the consolidated, I said only coming from many federal government realized the account of the federal government, because the consolidated account is a federal government account. So, but when I said, looking at the federation, the money going into the federation, because the money going into the federation account that's the state, that's the federal, the state, and the local government.
So what
And
you're
out of
saying
that money,
is that the money shouldn't come from consolidated revenue.
should come from the federal, because if it's coming from the federation account,
The point
there's
is
going to
maybe
be
a bigger pool. Excellent. So it doesn't matter whether it's 1% or 2%. If it comes from the federation account, even if it remains 1%.
that's the first part of it. Then we'll now look at the percentage.
Yes, they are.
We are going to look at it. So that's what I'm coming to that when I say the federation account. Because if you look at the federation account, coming to technological funding.
No problem. We don't have time.
The percentage
We don't have time. Percentage.
so the
Does it stay
percentage
at
may
one?
increase 3%
Okay.
of the federation account, so that everybody looking at the federation account.
Okay. Yes, my friend.
I mean, I know we say
So we have advocates
salary
who
rates
have adopted
for
states
buying laptops and
and made
other things when
decisions
we
to
take
that
care of
solution.
So
That is what has actually
I mean, if it's not transparent, the moment it's still not going to be enough. So looking at how to better track and monitor.
So yes, how do we do that? At the moment, there are tracking mechanisms. Dr. Gada is from the NHIA, so there are 4 gateways. Monies go from the.
Money tracking accounts.
How do we do that? How do we do that?
I'm
That's
saying that
suggestion.
at the state level, there is laws around announcing how these monies are being used and yes, announcing.
Just a moment, I'll come to you in a moment. So you talked about penalties, right?
No money at state level and national level. This one
when they get going, excellent. Because I'm very much just my friend matches. So just one suggestion, what we do how Maria
No, I think it's important.
it wasn't late. And that's the thing.
So for you, it's not about getting more money, it's about utilizing what is there.
It's time. It's time, but we can add 5 minutes. Yeah, to wrap up.
If you ask all of us in here, we have different ideas as to what ESPN means and what it covers and what it means. So they need to
what area that
increase
might
the knowledge. And now this is for beyond healthcare practitioners or suppliers.
the
People
skill
on the
of the
demand
health
side,
worker,
they don't know what the VAT
availability
is.
of commodities,
They
this is
know
really
what
blocked
it is meant
on the
to.
health
So
system.
we
But
need to
when
increase
private folks will come in,
knowledge around what the VAT is.
water, many private
Okay, so awareness creation has also come back. So just to show that those who are supposed to access
Different stakeholders have level of information.
wash hand before
let me give her the option because she has not spoken for the first time.
In terms of accountability,
Yes.
transparency, like you mentioned,
I've had to
it's
use
important to also create
emergency
guidelines, then present
that's
quarterly financial statements as to the utilization of funds.
at
These are the general purpose.
decent toilet.
So reporting, financial reporting is very important. Now, you are also coming from the private sector. So is it
So because the private
interest for me?
put their name
It
on
struck a chord.
to promote their
Would that
business
be
or
what
promote
would make
themselves
as private sector put money
key
into the business? And I'm looking at Dr. Ann and asking that question also. Because as of today, we are only concentrating on the money that is coming from the government. So the states are not contributing. We are saying the state should also contribute that. State contribution. Because if state contribution counts, 25% of the counterpart comes from the state. That will increase the pool. But because money is coming from the private sector at all. So make private sector contribute.
You need to trust. You see that accountability framework. You also have to clearly demonstrate the gaps. You have to clearly demonstrate the gaps. And speak of the private sector in a language that they understand. You have to make health, like I said, make health an economic issue, a business case. You have to develop a business case around health insurance.
It's an attitude issue when communities know their powers and they begin from starting their health communities. The health
That
workers
demonstrates the need for health insurance.
Okay, this is let me because we don't want the private sector
Sustainability is the last thing I'd like to talk about. Sustainability. So ensure that the mechanism for providing those funds are absolutely sustainable, not just dependent on that generated revenue.
so we share sustainable.
The day economy, the oil finishes, what happens?
It's not for oil. It's for revenue.
You see, 1% of revenue presupposes that government will always continue to have revenue.
There's nothing that will break government.
No.
Excuse me. What I'm they get it from us. They get it from natural resources.
Very nice. Yes. Yeah, it's not sustainability, right?
Yes, and then the trust.
Because we're no longer
Yes, in terms of the trust, yes.
comes to government.
Yes.
Sustainability cannot be about Nigeria was to get that done. They will maintain it. If they are in terms of health committee first, and that health committee will bring the primary health, the appropriate committee, what they can
then that
they bring the committee here,
saying you are taking 7% from the market to be the state
they'll bring the investors beyond their capacity.
Also, right from some private organizations that are looking for could be funded, and sometimes, like you mentioned,
we have 25 minutes to get to Congress law. If you miss that time, you can't go in after the Vice President, right? And you can't leave the premises. Okay.
So finally from him,
I want to marry.
Yeah, if you are going to the Congress law, we need to be in there for 12.
Okay.
So we need to be wrapping up now.
Very good.
I want to marry 2 points. The issue of trust and gap, which will improve participation of the private sector. Yes, the aspect of trust,
and they were not necessarily some organizations in health sector.
it's
They just supported with basic facilities, and there was work to do with government, and when how the distribution erected the structure, ensuring that we send healthcare workers their facilities working,
so when you have a phone and you say this is
provided alternate solutions. And what you mentioned is not happening. Is one thing that we're still looking for how to do it. Just working with stakeholders who were really in the private sector, also working with members of the community.
It's time. We don't have to have all the answers. So we're going to call on the Facebook to start their report.
Most of us are very good. But before then, we must for us to
Rapporteurs.
What are the different are some of the that's where forward, so we're all
Policy frameworks.
and main person to wear the non-Nigerian of American policy. And my interest that he is healthcare coming to this discussion.
Different aspects of one key aspect of quality. Section 13 and 14 issues in healthcare
challenges.
So both primary, secondary, and tertiary healthcare providers.
How much time do you have?
So we're talking about insurance for vulnerable groups, and then how can we make effective use of the funding that comes in, especially the ones that earmarked for this
have policy.
most of you know,
We have those who work closely with
Nigeria is
communities,
one of the countries in Africa that's behind in poverty.
persons interacting with communities and
Citizens on
so what can we say are the steps to
national protection for health
at any
in
level,
the whole of Africa.
any
It's
state,
something because of the reason I'm saying this is because all the policies
in terms of
countries that
having
really support in the World Health Organization
their strategic framework.
and yet has a YSR expenditure of about 72.5%.
So this is, I mean, it's pretty straightforward.
We do not think it's getting better by the day, because even now, based on the economic situation in the country,
Everything's been identified. So
it looks like we might be slipping back to
finance,
Indeed,
financing strategies to reverse brain drain. So
we
just
made a lot of
reverse
progress in health insurance in the country. As you know, in 2022,
and maybe we just take one of the
country
statements.
passed the National Health Insurance Authority law, and that law made health insurance mandatory, and based on that, the National Health Insurance Authority has moved forward to develop guidelines and plan implementation of the provisions of that law. In the previous we had recommended mandatory health insurance, so for us we see that this is the right step forward from where it used to be. Now the point is, having got the mandatory health insurance, and then of course we have the basic health care provision for non-industry. What progress have we made?
Don't run through the recommendations.
What do we need to
Get your
But
idea.
now this is what Nigerians get out of
When you have 10 minutes for
the process. So it's going to be very
the first recommendation,
interactive.
this was in 2020.
We have about 30 or 40 minutes less of the time that was supposed to have because we started late. But we're going to make good use of it. There are 3
With international
sub-sessions that we're going to have. The first is on mandatory health insurance.
Where are we?
And under the mandatory health insurance, we're going to be looking at what progress we have made in enrolling vulnerable populations in health insurance in Nigeria as we ensure mandatory coverage for all. The second session will be in terms of increased allocation to the basic health care provision. In this last session, we're going to be looking at the recommendation that was made earlier on increasing government contribution to the basic health care provision for those who need the basic health care provision from sources. One is 1% of the consolidated revenue fund of the federal government. Second is funding from donors, and the second is funding from other sources where we can increase private sector. And I'm happy that I have a lot of private sector representatives here at the banks and the rest of them. So those are the 3 main sources of the basic health care provision under the national health care. So what have we done in ensuring that we have at least 1%? So the recommendation was for fees to increase to at least 2%. And indeed, there was a movement so international agencies to begin to review the national health act and increase that to 20%. Where are we? The thought around accountability and transparency for health investment, especially around the basic health care provision and we are going to be looking at the systems that we have in place to ensure that even the little money that we have, though we are asking for more, but the little that we have, we are able to appropriately to get more help. So we're going to be dividing our time to be able to handle those things. But we're going to start first from the mandatory health insurance. We're going to leave this open. But we will not do ourselves any if we do not recognize the people in the room that have the manpower. That is why, because the DGNHIA is represented here by Dr. I'm going to give him the floor to speak to the mandatory health insurance. What progress have been made, then what systems are we going to place to make this happen? We're going to be going around by the time he's done. He's our go around for us to contribute to So we're going to look at the issues, what progress has been, and later we're going to be talking about what challenges we have and what possibilities we have.
Thank you very much. Dr. Francis has PwC very project. One of the strategies that actually all the employment budget, the National Health Insurance National Health Insurance so with the passage of that, set up three
Some do, and they share that same specialist among 3 or 4%. So, the private sector has a way of always finding a way of doing that. Anybody, any other ideas? Because when we talk about strategies, what are the strategies?
For more funds going here to the private sector through donors, investment, insurance, to also pull back to that particular fund so that the 3 million Nigerians that Nigeria Lancet talks about will be funded directly from Nigeria. And the implementation is going to through the state social health insurance. So when they fund so basically those are the issues like that we have. We're talking about responsibility of focus standards as
Yes.
And so when you implement society with high percentage of informal sector the population, you're always going to have challenges to poverty management. So that's what we need to have.
Thank you very much. I think it was very useful in terms of scale, in terms of where we are in our religious education, and so having passed the law, the next is really so guidelines have been developed, and some structures have been put in place. The vulnerable fund has been incorporated in the 2024 budget. What is the current status? And I understand that maybe as we are now applied right now by NHI to get some vulnerable groups into coverage or healthcare under the project. But when we have mandatory health insurance on that, it does not mean that it's going to be implemented. Now I open the floor based on what we know. What the progress. We are not exactly where we ought to be. So, how do you think we can move forward mandatory health insurance? So the law has said it is mandatory for all Nigerian, not only citizens, but all Nigerian residents. So what it means is that for the citizens of the country, and also for those who are working, legal residents who are also working in Nigeria, when they are not. Mandatory health insurance. Maybe I'm looking at you because you work in the state health insurance. What do you think that is the situation of mandatory within the state levels that are using for the implementation of health insurance?
Workforce, let's bear in mind that we're talking about nurses, so the basic level of something the community is actually here to provide you going to live in a rural area where she has no difficulty, where the primary health institutions so there are other and that help them might be it's actually also talking about that in terms of how do you
and so we see that annually we are using about 2,000 doctors, and then when we look at the current financing landscape,
we're going to get to that one. That's the second part. So if anybody has been going to say something else in terms of what are the current status of implementing the current recommendations, and their recommendation is so any other strategies that are
because we also have to sacrifice very creating things around subsidy of their consumption of power supply.
So you're going to begin to suggest to us what we I wanted to hear from Fauci health insurance program what because I know that the Fauci program is also so I wanted to know what progress we have some things already and we can come to where you are going to use this.
It's the same situation. One of the things about this issue of
20 minutes. 20 minutes.
And many countries are taking seriously cascade
that's it. So you've gone ahead to also discuss the possibility of integrating calculations some other through which
financing strategies.
yes. Oh, you can't get it. Okay.
Some difference. So you go ahead and one,
Okay, you can.
one, the issue of awareness. Because most people, especially the government, they are not aware of what is this education? How do I access it? What do I do to get the health insurance communities to the system. Exactly. There is
And to take the loan,
the funding is talking about. It's actually and that's the 1% from the consolidated pie. Shouldn't be when you say separation, it means the state and the local government are one moment. So what is talking about that the 1% is from the two and the three tiers of government. When you talk about consolidated, it's only the beneficiary is not the state. The state have to have for them now also have their own policy.
Okay, so you made very good point in terms of challenges, awareness, money is not available. So for the population, like you said, more important like the one that's coming from the federal government, coming from the continent, but it should come from the federation account. What we went ahead to say that the states should also participate again. So that the states also contribute.
But what I'm saying is, if it is from the federation, means the state and the local
that's the federation. You haven't made a suggestion.
No, what I say is,
oh, you didn't? Okay, that's okay. No, it's not true. That's okay. Indeed, the act has also said that the state should sanction their local security. That's one of the okay, mandatory health insurance is different from basic health insurance. Mandatoryness, why is it a challenge? Why is it a challenge? That's more important.
Sometimes people may take Nigeria and then to come back and
what you are saying is that the government should use the money to cover everybody. I'm not asking no, let's not go there yet. Mandatory, that's it.
And then I think it is also for health to be treated as a business. And when they were like a social marketing tool, something like regulatory. Right now, they are understanding as to how the competition is arising. So it is important to make it right. 1,000 naira covers per person. One of the challenges is that there is a lot of how they have arrived at the organization. And there is the inability to treat health insurance as lobby. Okay, right. Point of view, lack of understanding as to how the competitions are arriving.
I think that okay. Okay, yes, please go. Because you are from the first bank, I also want to deal with this while don't forget what you want to say. Because the law says that the knowledge of how the market, what it means is that there has to be some level of changing curriculum, newness of the market. So I wanted you to also look at that and what are the issues, what are the challenges, and then someone that guys in the private sector. Yes.
What I want to say is there's so much emphasis on the government's there's less attention to the private sector when it comes to health insurance. For instance,
So is it under private health insurance or under social health? So what we are saying is that so you have your private while the private health insurance you have to be a couple. That's what we're saying. So go ahead and you can answer that. What are the issues? Do you think it can work?
Yeah, it can work. It's actually
and he tells us who we need to talk to.
And also with
it's more like from data insurance.
The legislators have a huge role to play. Anything else? Maybe one more that we move to next. We talked about this. Probably get to anything. Okay, let's go to just get through two of them. So the second recommendation
it's basically by
increased budget allocation.
Every employer without being it should be seamless, it should be
budget allocation,
somebody
infrastructure,
domestic staff.
So question again, how far has the government progressed?
So there has to be like a system where things like this, I think the regulation doesn't really come down to monitoring.
To monitoring. Okay. Excellent. So thanks a lot. I think you've brought out very key points in terms of what needs to, in terms of the challenges we're having on the mandatory test. I have a hand here first, and then I go to you. Who soon wrap up on the mandatory health insurance. I know that's one of the key issues, but that's truly not my time, but we'll have to deal with that. So I have one
rounding up to now makes years from health, so that
nobody forced any of us to buy that. Army insurance, motor insurance has become less than 20% of the
Our 50%. Only if we look at the country,
10 minutes, please. 10 minutes left.
Yeah, it's not okay. Let's come to yes.
Who has can share his own experience. So the challenge is that when we get to these facilities,
So what would be your suggestion in terms of the way forward? Because that issue about the supply side has been raised. So what would be your suggestion in terms of what needs to be done?
the suggestion is that agencies that is in charge of
So you're talking about improving the quality so that it becomes attractive to those who want to buy it, and exactly that was the point. So would there be any other suggestion in that direction? Because I will move quickly.
So we want to end the standard for the network.
That's part of what MPA, that's part of why the new law
So if I want to invest in healthcare, the government can create incentives that make you want to invest not just in the cities, but also in, rural areas. If I have some tax benefit around it, then I'll probably I'm more incentivized to put in that investment.
So it's almost like in the way that
Yes, so one more so that we can
I like that. But in terms of
right.
who is responsible to the local government to be able to perform in terms of infrastructure when they are funded for their respective
So what do we need to do to deal with this? Awareness. Okay.
I think recently did an assessment of like
Okay. Very good.
We can also build on programs that have worked.
Okay.
That's peer review.
We have done health insurance in
how does that happen? This thing doesn't exist. Or there's one thing where
and learn from the people going back to making the same how far the government progress of the social registers that we have in relation to vulnerable populations. We have calculated that additional cash transfers that reach the informal sector. How do we build on this existing framework so that we're demonstrating that insurance also works is important. Proof of concept for me is another recommendation. We show that insurance works and then success stories from people who have benefited from it talking to the supply side now. And then success stories where people can show that because they have a reputation of 12,000 naira, their wives were able to have a cesarean operation and they paid nothing.
so it's clearly
So you wanted to say something?
So you will see they are different. They are very, very different.
Has already provided
If you have been on curtains, you understand? It's private medical vendors. They can do everything and
this year, not
Very good. So I want to go to the
So the question for again is what's the current function of states implementing a budget more
from the donors, the Bill and Melinda Gates Foundation are putting a lot of money into the system. The World Bank has some money, but as of today, services.
the capacity building for oversight.
For those has the basic
Because also with the new law and local governments now being responsible for
you can use that. We also have a discussion on the third part of it, which is accountability.
you know the thinking will never be a representation.
So let's say, what are the key
Get them closer to the people
and how do we go on to increase the
and to be able to
2% or more of the company?
build the
And how do
capacity
we
to
probably
believe
make
that
funding from the
would
other
that
sources?
be a much better strategy than those funds now being directed by the state? Because think about it, something like you might get
Like I said earlier,
it's not built in a
the 1% of the consolidated only coming from many federal government
and money has
the
come
consolidated
and comes like
the federal
so
government.
that's something yes, it's local
So,
government.
but when I said looking at the federation, the money coming into the federation,
and they will hold it.
because the money going into the federation is not
competition where that's,
that's the state, that's the federal.
that the chairman has to collect.
So what
And
you're
out of
saying
that money,
is that the money shouldn't come from the consolidated revenue fund. It should come from
because it is coming from the
Actually,
federation.
the point has been made a bigger pool. So it doesn't matter whether it's 1% or 2%. It comes from the federation account, even if we raise one.
That's the first part of it. Then we now look at the percentage.
Yes, they are.
We are going to look at the percentage coming to that when I say the federation. Because if you look at the federation account,
I'm going to go for
No problem, no problem.
no,
We don't have
I know
time.
the percentage.
We don't have time. Percentage.
So the percentage may increase to 3%
Okay.
of the federation account. So that everybody will be
It looks
like,
like you're also talking about what they say, lack of understanding language. You know what I mean? So you have to lack
There's a way the question really was increase budget allocation. But in a way,
So yes, how do we do that? At the moment, there are tracking mechanisms. From HIA. So there are 4 gateways. One is go from the. How do we do that? How do we do that?
Around how these monies are being used.
Just a moment, I'll come to you. So you talk about penalties, right? Excellent. Thank you very much. Yes, my friend. So just one suggestion. Maria. So for you, it's not about getting more money. It's about utilizing what is there.
It's time. It's time, but we can add 5 minutes. Yeah, to wrap up.
And what it covers, and what it reaches. Knowledge to refinance cases for, but beyond health institutions or people, suppliers, people of the demand side, they know what the VAT is, they know what it is meant to. So you need to increase, knowledge around what the VAT is.
Okay, so awareness creation has also come back. So just to ensure that those who are supposed to access
stakeholders have the level of information.
let me give her the option because she has not spoken for the first time. Yes. So reporting, financial reporting is very important. Now, you are also coming from the private sector. So is it talking about trust for me? Struck a chord. So would that be what will make us as private sector put money into the basic and I'm looking at Dr. Ann asking that question also. Because as of today, we are only concentrating on the money. So the states are not contributing to this. We are saying the state should also contribute. That will be their state contribution. But the state contribution counts 25% because they know that there is a cash from the state. That will increase the pool. Money is coming from the private sector. So what will make private sector? Trust. Yes. Okay.
A business case. You have to develop a business case around health insurance.
Okay, so we speak the language the private sector understands.
That demonstrates the need for health insurance.
Okay, business case. Okay, this is excellent. So, because we truly want the private sector to put okay. So,
ensure that the mechanisms to provide the hospitals are absolutely sustainable.
Okay.
Not just dependent on that consolidated revenue.
So ensure sustainable.
Revenue, resources that government will always continue to have revenue.
Sustainability is important. Very nice. Yes. Yeah, in terms of sustainability, right?
Yes, and then the
trust. Yeah. Yes, in terms of the trust.
Yeah.
Yes.
Citizens of South don't have trust. It's not in terms of government policy. Because always when they say policy, people look at the policy and just
so trust.
That trust, then that states institutions. What state of education is always like saying you're taking 2% from the farm, it means the state and the local government already from the farm.
So you have to talk about
Time up. Time up. We have 25 minutes to get to the Congress Hall. If you miss that time, you can't go in after the Vice President, right? And you can't leave. You can't leave the premises, right? Lockdown. Okay. Yeah, if you are going to the Congress Hall, you need to be in there before 12.
Okay.
So we need to be wrapping up now.
I want to marry 2.3 show price and gap, which will include participation of the yes, the aspect of trust will be for example, in terms of organization of this fund, it's by public facilities and how the distribution of credit in terms of utilization is private facilities have been so when you have a fund and you say this is exclusive,
okay.
It's time. We don't have to have all the answers. It's time. So we're going to call on the first group to start their report out. Group 1, Work Studio 1. Yes. Start. It's fine. Yeah.
All right. So thank you very much.
It's really rich.
So thank you very much. Thank you very much. It was a very good. My name is Franklin. Most of us have their very but for them, for us, we're supposed to have a graph patrol. Maria.
Rapporteurs. Where the gap is, where the options. What I've been given are some of the previous recommendations from perhaps you guys want to move forward so that we all
What stage is that? Excellent.
maybe we'll just quick. Maybe into where organizations depend on other, the perspective in a way that also coming this discussion. Maybe it's up to you.
Different aspects of
so on and so forth.
Good morning, everybody. My name is Professor Serayan, University of Application.
My name is Henry. I'm
My name is John Chidiago. I'm the Managing Director of Bristol Scientific. We're in the laboratory distribution space, and I'm also the co-chair of the Healthcare Committee on the American Business Council.
And the possibilities of the because I joined them some
So maybe what I'll quickly do is put the overarching question, because I think that would help guys in our discussion. So the overarching question, the overarching question we have to address is what financing how much time do we have?
I would say 40 minutes.
40 minutes. 40
Nigeria communities or other countries in Africa that these citizens on the world all the policies countries that support the World Health Organization and yet has the highest out of expenditure of about 72.5.
So this is pretty straightforward.
Do not think this is getting better by now based on the economic situation?
Everybody can identify. So
it looks like we might be slipping back.
But financing, money. Companies use financing strategies to reverse brain drain. So just to run through
health insurance you know in 2022.
And maybe we'll just take one of the statements and I'll ask questions around
that law health insurance based on that the national health insurance authority has been to develop guidelines on the implementation of the provisions. Previous so for us we see that
no, I think that's completely over.
Remember the question.
We will remember the question.
Yeah, that's what I was thinking. Just put it in the third one, we see it. Okay. Yeah, just the arterial. So I want to run through the recommendations and really get your idea. Well, you have time, 10 minutes, so that's not so that's good. The first recommendation, this was in 2020. You know what I mean? So the first recommendation is employ a strategy for protecting with international financial professionals. Where are we by attracting health professionals?
in the ruling population social insurance in Nigeria.
One of the recommendations
Second,
So now where are we
in terms of increased allocation to the healthcare provision. That's the recommendation that was made earlier.
And then how
On increasing government contribution to the for those who
understand
So presently, I'm not aware of any strike on the fact that at the Ministry of Health, the PDP and the diaspora unit was established of the director in charge, and the aim was to
those are the three main
give diaspora, clinicians, doctors, and the like, what a soft landing if they want to
ensuring that we have was for
PDP and diaspora unit was at the Federal Ministry of Health. So that unit exists. And so if somebody is coming from diaspora and probably establish something in Nigeria, that's the unit you go to for proper guidance, whatever incentive that is available. But ultimately, is a capital market. It's a demand and supply sort of thing. So you have to deliberately create the community that we have to be able to attract somebody who has been an economic migrant back home, to practice within the system. So the financial incentive has to make sense. And these days we're then here for other reasons. Because you need to think about the push and the pull factors. The other reasons why they have run out in the first place. Security, do you understand? Infrastructure for development of their kids and the like. So it has to be holistic. And I will work with the project that I'm involved in as well. So basically, I will just share my experience while you probably know about the AMC, the African Medical Center of Excellence, being built by Afro-Asian Bank. Yes, and then we operated by King's College. So I work with PwC on that project. And one of the strategies is actually built around the employment strategy was built around attracting diaspora, Nigerians diaspora to work in the hospital. To that effect, a lot of the professionals, different specialists that were involved in the pre-implementation phase of that conversation were Nigerians, either at King's College or in the US and different places, already at the point of conceptualization, they were brought in to make inputs. Now the strategy is to bring them back and then give them commensurate incentives in terms of wages, other incentives, travel incentives, living cost incentives, to be able to attract them back to the country. And that is what is going on right now. Recruitment is ongoing as we speak, and a lot of those people have been co-opted into that project. But it has to be a project that has capacity to pay. And Afro-Asian is able to do this because of the level it intends to operate the hospital. The level is intended to run the hospital. Now the question is how many private hospital practitioners in Nigeria today can afford to bring in the professor from the US who is in Nigeria, who is probably $20,000.
There are methods to do that. There are practice communities that some do, and they share that same specialty among 3 or 4 facilities. So, private sector has a way of always finding a way of doing that. Anybody, any other ideas? Because when we talk about strategies, what are the strategies?
what we can do as a group is also more funds going here to the private sector, and again because donors, investment by the international agencies to also pull back into that particular fund, so that the 83 million Nigerians that the Nigerian Lancet talks about will be funded directly each year. And the implementation is going to be from the state social insurance agency. So when they
For me, I feel that that should be the starting point.
collected at the same time, pulled together,
The problem is how well they do it.
so basically those are the issues
Filled with a lot of good ideas, particularly talking about focusing on health outcomes, working in rural areas,
Yes. And so when the demand of society with high percentage of informal sector, have challenges of making that migration. So that's why we need to
Thank you very much. It was very useful work in terms of where we are. So having a tax the next is because so guidelines generally explain how we have a wonderful fund because of that inappropriated release of work for budget. So we can't I don't think that is there's no one way to apply right when we have the money, does not mean that now I open the based on what we what you send our children to secondary school. We don't we're not doing nothing exactly where we have to still offer it where the public school system that's still so the law has said these for them in Nigeria, we need school fees primary education stuff like that. But something to really remuneration is working. Legal residents are also working where they are. Maybe because you want even on the state what is the that's economic situation where is the situation everybody has to pay we're talking about costs that are units of the insecurity as well. All these things put together. What is the potential? But if some of these
when we say health workforce, let's bear in mind that we're talking about nurses, we're talking about community workers, community health workers. So the basic level, somebody in the community may actually be a trained nurse. But why don't you go and live in a rural area where she has no basic contact, where the primary health care facility she has to work is not the best, or she's not the best. So there are other, and that helps with my but it actually also talks about the diaspora in terms of how you attract people back to Nigeria. So
I want to say that current statistics have shown us that the health sector is facing a lot of problems, inadequate infrastructure, insufficient funding, limited access, shortage of health workforce. And so we see that annually we are losing more than 2,000 doctors, nurses, they are going to other development countries. And then when we look at the current financing landscape, I think that Nigeria is currently allocating 85%.
We're going to get to that one. That's the second part.
Oh, okay. The solution.
If anybody has anything else in terms of what are the current status of implementing the current recommendations, and their recommendation is practicing house workforce. So, does anyone think of any other strategies that are in place? Yes. Talk about
I totally will consider, because they also have to be saddled by the very hostile but creating things around subsidy on their consumption of power supply, all of those important things. The other factor for quality, we just keep going to whether there's any form of benchmark being done for us as a country, at a national level, where in other countries that have situations like ours, how they are impacting if I'm not, really actually looking at it, there must be a way. It's not, which is not notorious for Nigeria to Africa. A lot of other countries migrate.
It's the same situation. One of the things the policy actually speaks to is this issue of health diplomacy. I think that there are
20 minutes. 20 minutes.
And many countries, for instance, US, keep recruit health workers. So part of that policy, the health depends on the issue of health service. Part of that in terms of
so I know for instance, I'm not really
financing strategies.
It has to be an incentive-based scheme, because even in the developed world, I know with some states go ahead to pay off a student loan of a young doctor, okay, and then give them some years of employment that was mandatorily work in the state. Sometimes about 10 years, you understand? And this is talking about up to $200,000 they will take care of it. You understand? So it has to be financial.
Health insurance.
And to pay the loan, they have to sign the loan forgiveness, the health and government, and
yes, of course. They sign a bond. You can call it bonded employment.
Which is not
what if the company actually gets paid for releasing their
we should put a tariff.
Look at what else can you like?
Because don't forget, especially, I mean, I attended the course, what did you do? Yes, I know, paying commensurate school fees to graduate as a doctor. So if
Can you think of potential bottlenecks towards obstacles to implement they have workforce migration policy.
the bottlenecks.
Political will.
Okay, so you made the point
Yeah. We can have policy without the, just on paper without the political will.
Let me even expand that further. Let me expand that further with what I do as government. A government may have the political will to implement a certain project, like we're saying. But if the government coming, you cannot guarantee that
Continuity.
So that will continue. What I'm saying, you know,
Policy consistency.
So you haven't
what I say, you know, I did international.
Okay, that's okay. No, it's not true.
That's okay. And
we do the actual
I don't want to talk about civil servants in the state were paid a token from their monthly wage. And so, like an insurance. So when you fall, you don't need to have money in your pocket, you just go there. The next government came and cancelled that scheme. And they pay short term. Okay.
Yes. Infrastructural deficit.
Upon each of the registration, sometimes people may turn to Nigeria, they leave, and then to come back, and it's happening. So things like I know they have a transaction, so
no, let's not go there yet. Mandatory next year.
So that's also helping. Yes.
So regulatory agencies.
Marketing
What we think by regulation.
Since we're talking about healthcare workers, it applies to skilled dentists, it applies to other
Okay, maybe we can what remains is what any
monitoring and evaluation. They should monitor all those policies of
lobby
community engagement, stakeholders engagement.
I think that they're giving too much of
Okay, yes, please go. Because you are from First Bank, I also want to do this while
stakeholdership needs to happen there. Because based on the knowledge of how the market is evolving, there has to be some level of feedback, changing curriculum, embrace the newness of the market.
I wanted you to also look at that. I wanted
what you are saying is that is what the market needs, what's the ambition. Yes. Because here also this
and needs assessment, annually, you can embark on it.
Yeah, so just like needs assessment or
the health workforce needs what to be done to retain and to retain the children. Advocacy is better.
Advocacy is lovely. Expression is like
lottery comes under advocacy.
Yes,
and he tells us who we need to talk to.
and also with
What are the years to do?
the legislators have a huge role in this. So anything else? Maybe one more, then we move to the next. Probably get to the
Yeah, they can support us survey and they come out with their findings.
Okay, let's move to maybe we can just get through two of them. So the second recommendation, which is what Madam you alluded to, the second recommendation is increase budget allocation to healthcare, prioritize infrastructure development, and capacity building and non-workforce. So this talks to budget allocation, infrastructure, and capacity building as recommendation. So question again, how far has the government progressed in increasing funding to health sector, workforce development, and capacity building? So it's three breakdowns. So the three recommendations. Breakdown.
Excellent.
I think we need to harness.
Very key in terms of what needs to so the challenges we
The first one is the
I have a hand here first, and then I will soon wrap up on the
and then the second one is
I know that's
So recommendation is to increase budget allocation.
yeah, infrastructure development.
What should we do?
Yeah, what should we do? And the third, these are all part of the one recommendation. The third is capacity building. So the question is, so the question there is how far to went infrastructure development, capacity building.
Motor insurance and
Who wants to go first? Budget allocation. Our budget 50%.
No, that's
For now, I think it's around 5 to 7 to 8.
If you look at the country, it's not 50. Any states actually 50.
10 minutes, please. 10 minutes left.
yeah, it's good. Okay, let's come
It says minimum one, it's total one. Right?
But how, in reality, how does this really impact?
Because ultimately, but the thing would be, by increasing the budget or the funding to the health sector, that would now enable capacity building to run. In terms of budget allocation, the thing that brings the two funding streams that actually fund the primary health care. So one part of primary health care is supposed to get
So what would be your suggestion in terms of the way forward? Because that issue about the supply side has been raised now. So what would be your suggestion in terms of what
MCD gateway activities to enable infrastructure development of primary health facilities. Part of it is also to support health workforce. Of course, the normal ensure that precision medicine, ensure that the labs are there.
All of this is fantastic.
So you're talking about improving the policy so that it becomes attractive to those who want to buy and exactly that was the point. So when you get any other suggestions in that direction, because I will move quickly.
Well, that's part of what FDA, that's part of why the new law has now given power to local governments. So previously, that went to the local government, immediately went up to that was the new that suspended local government. That funding is now going to go to local government. So it's almost like taking away that,
Yes.
you know,
Let's look at it. And I like that but in terms of who, so I think the military landscape, who is responsible to the local government to be able to perform in terms of building infrastructure when they are funded for their respective
well, technically, that role, that oversight role,
So what do we need to do to deal with this? Awareness.
I think recently NPCA did an assessment of like the
Very good.
We have done health insurance. That's funding.
How did that happen? Like, this thing doesn't exist. What they funding where nobody knows. So, question back to how far has the government progressed in funding for healthcare? But is that right? Because if we're saying that there has to be funding, why is that not translated to
How do we
so the purpose before we talk about more money, money that's now allocated.
demonstrating that insurance also works is important.
This is why we
successful where people can show that because they have an expectation of return their wives were able to have this area of operation.
So there's clearly a gap. There's clearly a gap. So when people money will happen, money has been
yeah, but it's easy to spend the money. Yes.
So this means they need capacity building to be able to
accountability.
Yes. It was just being clear. If you couldn't talk about the use of example, because he knows if you hold, they can change that's how we implement.
So back to so given all
it's about capacity too. I know a situation like spread out in agencies in applications. This agency had foundation form. They notified them January 6 months down the line, your money is going to recover if you don't spend it. They sent an email to say, you are not, you understand, you are not at all. Yes, they didn't do anything and that money was recovered. This year, not last year.
Everybody scares Nigerians. Really hard.
No, and this is an agency that if really wants to spend money, if they has capacity to do that, there are so many programs. In this
very good. So I
know the safeguard of this kind of institution.
that number of safeguards are very to change it to accountability and transparency
That's what it is. Safeguard.
that's transparent.
because that is more important to me. Nobody can be accountable without being transparent.
That's what happens in this
So in the question for again is what's the current kids implementing more budget, more bank service. The challenge though is we're talking about more funding to help with the work. So now, before we talk about implementing this,
How was it?
Capacity, I think I put capacity building for oversight. But also with the new law and local governments now being responsible for planning on this.
It sounds scary to me.
You know the thing
because local government have never been known to say informing for anything.
If they're closer to the people in the region and be able to build their capacity in terms of accountability, would that be a much better strategy than those funds now being direct by the state? Because think about it, that's something like in my village, local tenant is not building a health facility. People in this community will be like, oh, that, or they can face business. The accountability is there. These are your peers. There are certain places
We have many success stories.
people know that you have not spent, and money has come up and you haven't spent it. So that accountability is, yes, it's a local government, but it has to be a community accountability. It has to be a community accountability as well. The community will know how much money has been spent, and they will hold this community.
So that the community is aware that, through a process, an engineered process, that the chairman has collected money.
So
community engagement.
Yes. The point has been made, the bigger picture. So it doesn't matter.
They have
so empowered at this moment.
Yes, local, the government has to strong for that. People will be
yes, they are minorities.
So
I just
No problem. The percentage, they don't have time. Percentage. So the percentage of the federation.
it looks like we also need to talk about the language. We say, we're talking about bottlenecks, and we're saying capacity building is bottleneck. Lack of capacity, language. That's all I mean. So you have to lack of
So in a way, the question really was, what is our recommendation was increase budget allocation.
So what is being done in those
But in a way, we are. The question is, yes, there is.
So yes, what we do at the moment, there are tracking mechanisms, and the guy is retired. So there are 4 gates where money is go from the. How do you do that? How do you do that?
But not having an accountability framework and money, like if they bring it home, my neighbor, you see the money is
Just a moment, I'll come to you.
these guys are on another level. So without that, I'm really tired.
So that's what we're talking about the
The question is, what can I can just
performance indicators that monitor certain performance indicators.
And the people, and the organization that has umbrella policy so that engages with our
So for you, it's not about getting more money, it's about utilizing what is there.
Before you can talk of accountability, you must know what you are doing. Capacity indicators you want to check.
It's time. It's time, but we can add 5 minutes. You have to wrap up.
The accountability framework that we use we will do ahead of them. Yes, so to review the capabilities for what exists. Capacity.
So for capacity, are we thinking for the health workforce?
Because in terms of health workforce,
So awareness creation has also come back. So just to ensure that those are supposed to access care. Let me give her the option because she has not spoken for the first time.
I know that levels of preserving
What about security? It's part of the challenges. Some doctors are being hijacked and kidnapped.
So reporting, financial reporting is very important. Now, you are also coming from a
Insurance scheme for the doctors.
That's a challenge. That's a challenge.
I'm looking at this asking that because as of today,
Yeah, because once we introduce that, it opens up the secondary market in it becomes a market because they know that there's an insurance and they're helping pay. It's just like families having insurance, life insurance, and the beneficiaries from that life insurance
because they are high risk people. Why are they not selling the nation?
I mean, again, hazard allowance, we have hazard allowances.
What? Hazard in the workplace.
Because hazard is not.
More collaboration and partnership, public and private sector.
okay, this is
overall healthcare.
Yeah, but that's a problem. Everyone needs to know.
Imagine that the hospital is in place, the money is there, but the people are not just coming out.
very nice. Yeah, in terms of sustainability, right? Yes, and then yes, in terms of it, right? Yes.
If you work with the citizens of the get out of
Time up. Time up. We have 25 minutes to get to the Congress Hall. If you miss that time, you can't go in after the Vice President, right? And you can't leave. You can't leave the premises. Lockdown. Okay.
So finally from him,
Yeah, if you are going to the Congress Hall, you need to be in there before 12.
Okay.
So we need to be wrapping up now.
Very good.
So, but sorry, for the private sector.
Yes.
Okay.
It's time. We don't have to have all the answers. So we're going to call on the first group to start their report out. Group 1, Work Studio 1. Yes.
Yeah, so we really got
So it's fine.
so much.
Yeah.
So much to discuss. I have to stop.
All right.
It's time. We don't have to have all the answers. It's time. So we're going to call on the first group to start their report out. Group 1, Work Studio 1. Yes. Yes. You start.
We really got
The 2, it's fine.
There was just so much to
Yeah.
discuss. I had to stop them for get some. It was really rich discussion, so we had to stop. Okay, so maybe we can feed back to. All right.
Okay, so I think you can stay where you are. Just, turn your seat if you have to. Thank you. So we'll start with Work Studio 1. Work Studio 1. Health Workforce, Reversing Brain Drain. Thank you. Please, we are restricted on time. Sorry. I know the ideas are great, but please.
How much time do we have for feedback for each team?
For each team, you have about 3 minutes.
Oh, wow. Okay.
3 minutes. And then we need to have time for some discussion and questions, etc.
Okay, thank you, everybody. We have not a lot of time. Thank you so much to an awesome Group 1 for brainstorming around how do we finance the health sector to attract our health workforce. So our overarching question was, what financing strategies can effectively attract, retain, and develop the health workforce in Nigeria, thereby reversing the brain drain? So one of the first recommendations from the 26th NESG Summit was employing a strategy for attracting Nigerian medical professionals and human capital with international credentials to return to Nigeria. So how do we attract our health workforce in the diaspora to come back to Nigeria? And the question really around that was, what strategies are actively being implemented to reverse the brain drain? And what specific incentives are in place to ensure that happens? So using the framework that we were given of what's the current status of recommendations and what's currently being done. So some of the things we talked about were, first of all, a PPP unit in terms of strategies that are being put in place.
Attention, please.
A PPP unit
Work Studio
within
2.
the Ministry of Health and a diaspora unit, whereby people in the diaspora can come if they're interested and speak to that unit about opportunities to invest in the Nigerian health sector. Another strategy that's already in place, and this is more very private sector and academia driven, is AMC. This is a partnership with Afrexim Bank, working with King's College. They're looking to put in place, I think, about 3 or 4 health sectors of excellence across Africa. And I think the very first one is going to be in Abuja.
I think that's a 500-bed facility, and it's currently being built. I think the completion date might be in the next year or two. I'm sure somebody may know. And that's another strategy that's put in place to attract the diaspora, because this Center of Excellence is going to recruit health workers to come back, but it's also training a cadre of health workers to also work in this new facility. Then there's a new health workforce policy of migration that was launched by the Honorable Minister of Health. And this addresses many issues around attracting the diaspora to come back. It talks about how can we strengthen our health diplomacy. As we know, there are current codes of practice that countries are supposed to abide by and not poach staff from, especially low-income countries where we already have a deficit. But this policy is a code of practice and it's not enforceable. But how can we as a country, I guess, be more bullish and ensure that we are not just losing health workers to other countries and they're not coming to Nigeria just recruiting? So this policy is looking to address that. Other things that we also talked about is putting in place low-interest loans. So if people want to come and invest in Nigeria, how can we, with Ministry of Budget and Planning and Finance, put in place incentives like low-interest loans, enabling them to invest. Something we talked about earlier, but not maybe within this group, is also some of the bottlenecks that people face when they're coming to invest in the health sector in Nigeria. How can those be overcome? And some of those bottlenecks include things like, customs. You're importing goods, but you're spending maybe 3-4 months just clearing one item that you need in your facility. That's definitely a disincentive. And then something we talked about, which is, I think, quite reasonable, is when we have our health professionals train in Nigeria, are we able to ensure that they have a mandatory minimum period of service? Because as we know, our health workforce is subsidizing the global health workforce. So people in the US and UK spend a lot in training the health workforce, whereas we do the same, we spend our resources and then they leave. And what do we as a country get back? So is it possible to have a mandatory minimum service so that at least the training, that the investment that's been put in them, we at least reap some benefit from it? So in terms of what are the bottlenecks and obstacles for some of these, we talked about political will to implement. It's good as well, and it's all well and good having a policy, but then policies are great. We're very good at them in Nigeria, but implementation is another story. So how can we ensure that the policies that's already in place is implemented as much as possible? Ease of registration. So that's definitely a bottleneck for people in the diaspora when they want to come back and invest or at least set up. The process going through MDCN and others can be a disincentive. You want to come and re-register. You trained in Nigeria, you left maybe 10 years, you come back, but just re-registering to practice in Nigeria can be a disincentive because it's not an efficient process right now. And then lack of continuity between governments. So one government will come and put in place a certain policy, then the next comes and decides, no, we want to do it a different way. Then you're almost back to square one and nothing ever moves forward. Then funding, of course, to implement these policies. Policies are great in paper, but then behind them needs to be a funding mechanism to ensure they come to fruition. And then infrastructure gaps, which I think I can talk to in the next section. So what can NESG do? I think I might be running out of time, but at least let's get through one of the recommendations. So what can NESG do? We found that NESG can do some direct advocacy to academic institutions, but also advocacy to legislators who have an important role to play ensuring that some of these regulations actually get tabled. And engaging regulatory bodies. So when we talk about MDCN, Medical Dental Council of Nigeria, and then of course Nigerian Medical Association and other regulatory bodies, NAFDAC, etc., how can NESG support ensuring that those bottlenecks are not obstacles? Then of course stakeholder engagement. We have to ensure that the very people who these policies are put in place are part of, working and coming up with the solutions. I think that's it for the first. Do we have time for the next one? Yes, I'll go to the second one. So very quickly, the second recommendation to address the financing strategies is increased budget allocation to healthcare and prioritize infrastructure development and capacity building for health workers. And the question asked is how far has the government progressed in increasing funding for health workforce development, and what could be done better to utilize the funds for capacity building? What we've thought as a group is, yes, we talk about always increased funding, but one thing we know is the available funding, how efficiently is it being used? Do we have strong accountability mechanisms that ensure that funds allocated are used for what they're for? There's transparency in the use of these funds. Recently, we know the local governments have got greater powers now in running primary healthcare facilities. How will that impact allocation of funds directly to primary health facilities? What accountability mechanisms are there in place? And do we have sufficient capacity at that local level to ensure that those funds that are allocated to primary healthcare, for example, are being used? Are there community accountability mechanisms that can also be put in place? So in terms of how far this has progressed, some states are allocating at least 15% of their budget to health, Kano being an example. But across the board, Nigeria as a whole doesn't allocate up to 6%. So there definitely, we do need more funding, but before we push for more funding, we have to ensure the available funds are being used efficiently, and people who need access to health through increasing enrollment in health insurance ensures that people who need to access healthcare do so. And ensuring that we have more funding into the health sector should have the impact of increasing funds that are allocated to health, and thereby we're able to hopefully retain our health workforce. Now, in terms of what NESG can do, can NESG support in strengthening some of these accountability frameworks and mechanisms? The body that has the responsibility for local health facilities is ALGON. Is there ways that NESG can strengthen their capacity and work with them to retain health workers, especially knowing that we have a lot of migration from rural to urban areas? And we know that a lot of the health challenges are at the rural, in the rural facilities. So in terms of retaining health workforce, that's an area that we think NESG can support in, as well as facilitating public-private partnerships that would incentivize the private sector to invest in healthcare, thereby financing and increasing funds that would lead to retention of health workforce. Thank you.
All right, Dr. Laz, I'm under pressure. So I think maybe just go straight to the recommendations to NESG. Yeah, to NESG, so that we can spend 3 minutes. Later on, we can have a debrief and maybe harmonize the notes from all of the rapporteurs. Thank you.
Okay, thank you very much. My group were quite active and discussed a lot of recommendations. And one of them was essentially, but let me mention generally, we talked as citizens, the expectations of Nigerian citizens in relation to quality and access to healthcare. So our discussion is essentially as citizens of Nigeria. So we recognize the fact that what is quality healthcare? How many citizens can answer that question? What is quality healthcare? We also recognize the fact that Section 13 and 14 of the National Health Act 2014, which recommended a certificate of standards for all health facilities in the country, has not been implemented 10 years after, despite the fact the Act giving 2 years for that implementation. So we strongly recommended citizens' education and community awareness, and this will also include awareness on budgets for efficient utilization of resources. If citizens know how much is going into their healthcare and what it's meant for, they'll ask the right questions and hold necessary persons accountable, as Mrs. Vivian mentioned, accountability. So we feel that community governance structure should be strengthened, the village health committees and the community health committees, as the most sustainable way of ensuring accountability. civil society organizations might go and leave, any other group might go and leave, but those governance structures at the community level are always there at any time T. So if we get them to do that, that will be most sustainable. So specifically to NESG, okay, public-private partnership, we recognize the high-level PPP that is more popular, but at the community level in relation to quality healthcare, we're talking about the private medicine vendors, those we popularly know as chemists, as key stakeholders in the private sector there, small businesses, religious institutions as key private, potential private partners, and how they could intervene, especially in the area of providing power supply using renewable energy options and other sustainable local options, providing water supply in all health facilities, and how those are related to quality healthcare as well as sanitation facilities, which are very important. So we feel, number one, for NESGs to help to promote this public-private partnership. We know at the supply side is a very popular language, but on the demand side, in this case, at the community level, the public parts being those community and village health committees or ward development committees, the people themselves, and the private being those local private sector stakeholders. So this could be strategically promoted in a sustainable manner using things the community will be able to maintain in line with the principles of primary health care. Then NESG could also help to promote the strengthening of these community governance structures as also provide accountability to ensure efficient use of available resources. And number three, monitoring and ranking. We feel one campaign, National Advocates for Health and some groups did a ranking a couple of years ago of state performance in primary health care. This could be taken to a different level. What's the standard, what's the quality, and how are the states performing, and how is the private sector performing? So with this monitoring and ranking in terms of access to quality health care across all states in Nigeria, it will help those who are not doing well to step up. So we feel NESG could help in making this possible. Thank you very much.
Thank you, group. Sorry, I skipped group 2 to 3. Work Studio 2. It was only after he started I realized. So Work Studio 2, health financing.
All right, thank you very much. Very quickly here, we dealt with 3 sub-themes. 1, mandatory health insurance. 2nd, the basic health care provision fund, increasing the funding around it. And the 3rd one is improving accountability for the basic health care provision fund. I'm going to take them very quickly. For mandatory health insurance, we know that the country has passed a law on mandatory health insurance in 2022. And moving forward, the NHIA has developed guidelines for implementation. But as it is today, the implementation based on the conversation that happened in this group is still very slow, even at the state levels that are the units of implementation. So what are the recommendations? Number 1 is for the NESG to follow up with the implementation of this law and its guidelines, especially as we have an experience in Lagos where an executive order, the governor had issued an executive order for the implementation of mandatoriness. So can we have such an executive order also from Mr. President on mandatoriness of health insurance? And we are saying that other states can also take a cue from Lagos and issue such executive orders for the implementation of mandatory health insurance in their states. We know that the law has also provided that the NHIA will be a regulator, integrator, and a promoter of health insurance. To what extent is the NHIA supported to do that? So we believe that the NESG can also work with the NHIA to provide those functions that are already in the law. Can we show successes? are there success stories about how insurance is working? Because this group recognized that the health-seeking behavior of the people is poor, and then their uptake of health insurance is also slow, even for those who can pay. Of course, we recognize that there are two groups, those who can pay and those who cannot pay. So for those who cannot pay, they will be paid for through a number of mechanisms, including the Basic Healthcare Provision Fund and equity funds of the states. But for those who can pay, that are not paying, so can we show success stories so that we can also improve their trust and their participation? The next is for the state health insurance programs. We know that the NHIA has developed their blueprint that has 4 pillars. One of them is improving coverage, which we are talking about on the mandatoriness. Is it possible for us to also provide incentive for states to be able to do this? And how can we do that? I like it when Dr. Laz was talking about ranking. So can we also begin to rank states and then ensure that they compete around improving coverage? I see Caroline and team, they are supporting in ensuring that the leadership challenge for primary health care is working at the state levels, because they are holding governors accountable by ranking them and incentivizing them. Can we do the same in health insurance to ensure that we improve? The last I'm going to speak to, because I'm going to take the 2 sub-teams of Basic Healthcare Provision Fund together. So the Basic Healthcare Provision Fund at the moment is working at the state's level. Implementation has happened over the last 5-6 years. The money we have there, everybody recognizes, even in this team, is not enough. So there is a recommendation, there was an NASG recommendation for the Consolidated Revenue Fund to move from at least 1% to at least 2%. But people in this group are saying that, that we should look at federation account. That even if it goes up to 3%, that's okay, but federation account is better. They are also looking at the accountability, because it looks like monies that are going down, people are not very sure of how it is. So can NASG support with the accountability mechanisms, especially at the state level? There is an issue around awareness. So can we also create more awareness, especially at the community levels, to be able to hold this accountable? And finally, there is issue of private sector engagement. There is, the private sector players here are saying that there is little or no incentive for them to engage, because they do not trust what the government is doing. So how can government create that trust to make them put money into the Basic Healthcare Provision Fund? Because as we know, the Basic Healthcare Provision Fund should be from government. The other source is donor partners, which some of the donors, including the Gates Foundation, is doing. But the private sector is zero as at today. So how can we create that environment for the private sector to thrive? Let me stop at this point. I want to thank every one of us in our groups, and then also thank the organizers for making this possible.
All right, thanks so much. I was actually meant to summarize very quickly what we'll take. Can I do that? Sure. Okay, thank you. All right, so from group 1, we'll check with you later to make sure that we actually got all of your recommendations. But I have 2, and that's around HRH. So direct advocacy to academic institutions and to the government. And this is around engaging Nigerians in the new centers of excellence that are being built, and low interest loans for health workers who want to set up their businesses. So that's what I got. I hope that's correct. And then more fund allocation overall. I think that ties in with group 2. So when there's more funds available, then there's more to invest in human resource for health. And then engagement with Algon, considering that they also now have resources. I hope that's what, and accountability. Now, Work Studio 2, which is the one we just had on, quite a few recommendations. So follow up on the implementation of, or the mandatoriness of the law, pursue an executive order similar to what was had in Lagos, making health insurance mandatory, engage the NHIA on its other functions, regulatory, etc., showcase success story on how well health insurance can work, especially for those who can pay. That's the lower hanging fruit. And lastly, states' health insurance schemes. Can we start ranking states and foster competition? Okay. And then for the BHCPF specific ones, it's better to focus on federation account over the consolidated revenue fund, foster accountability, and provide some support mechanisms for that. Create more awareness at the community level on the BHCPF, and I think this will also foster accountability. Lastly, private sector engagement, because currently there's little to no incentive for engagement, and there's a lack of trust. So therefore, the private sector is not contributing. So we have those. We'll reach out to make sure we captured all the points, but I think these are some good points that we can move forward with for the next year. Thank you so much for your contributions. Really appreciate it. Hopefully next year when we come back, we have a few positive reports to share. I just saw Greg now. I was wondering, no microinsurance. All right, thank you so much. Thanks, everyone. So now we'll move to the Congress Hall. We have less than 2 minutes to get there. Oh, and one more announcement. This QR code on your tag, that's like a business card. It has all your contact details, so you can share them with people if you don't have your business card. I've been asked to share that with you. Thank you.